Hi, my name is Catherine Schesta. I'm a nurse anesthetist here at Freighter Hospital. I'm one of about 4 or 5 CRNAs that work on the anesthesia team with Dr. Evans and Dr. Christians. In addition to a nurse anesthetist, you'll also be being taken care of by an anesthesiologist. So what always happens is we will pick you up to go to surgery in the pre-op arrival and recovery area. Your Mediport will be accessed by the nurse there, and IV fluids will be hooked up. From there, we will take you into the operating room on the cart. So we arrived to the operating room right now. It is a little chilly in the operating room, but we will give you some nice warm blankets when we arrive. There is a lot of equipment in here. Everything has a purpose, which we will be describing to you very shortly. Once we bring it into the operating room on the cart, you will be met by Eva, the operating room nurse, as well as Shira, the surgical tech, and Brittany, the surgical coordinator. So Eva then meets me here with the patient, and we will both do a check-in process.
Morning. My name's Eva. I'm a circulating nurse here in the operating room, and this is Brittany, another nurse with me, and Shira, who's Dr. Evans' right hand. She's a surgical tech here. And so together with Katie and the anesthesia team, we all work together as a team to take care of the patient and advocate for the patient and be their voice while they're here asleep. So when they come in, we greet the patient. We always start out with a final verbal safety check, identifying their name and what they're having done, allergies, etc. And then we verify we have blood available for these procedures. We always have at least a couple of units cross-matched for them. And any drugs that we may need, we usually get ahead of time and confirm with Dr. Evans that that's correct. So the first thing we do is we put on these sleeves. These are compression stockings. We put them on the lower legs, and it prevents blood clots throughout the surgery. It's routine for every procedure. Then we explain to the patient, we move them to this table, and this is a one-size-fits-all bed. The patients will move over here. We have heating blankets underneath, and then we also have another unit here that attaches to a blanket that goes over the top of them, so it keeps them warm while they're here. Patients often complain how cold operating rooms are. We usually position a pillow under their knees to make sure their back is comfortable, and put on a safety strap for them. And then Katie goes ahead. That's our part, pre-anesthesia, and then Katie goes ahead with her part.
This is the area for the anesthesia. I know it looks a little bit overwhelming, but once the patient is over on the table, like Eva mentioned, we kind of work as a pit crew. So Eva is taking care of the STDs and the warming. The patient, you'll be over here at the head of the bed. We'll put all of our safety monitors on you. All of our safety monitors is a pulse ox, the clip, a blood pressure cuff, and then also the EKG patches, 5 little stickers to watch your heart. At that point in time, we'll just have you breathe some oxygen through a mask. It's just oxygen. There's no medication. It's a little, kind of smells like plastic, kind of like a beach ball, but we'll have you breathe 100% oxygen for a couple minutes. At that point in time then, we'll be drifting you off to sleep. You have probably already had your Mediport access, so no other needle pokes are needed. We'll drift you off to sleep with medicine through your IV. Once we confirm that you are asleep, then we will be placing a breathing device that will breathe for you during the surgery. We accomplish that by using sort of a metal tongue depressor. It'll go into your mouth. Once we find the right area, we will place a breathing tube. It'll go into your mouth and down your windpipe. Once we confirm that it is in the correct spot, this is the anesthesia machine. We have anesthesia gas, and then the breathing tube circuit, which we will hook you up to. So obviously you will not know that this is happening. We will keep you asleep with the anesthesia gas through the breathing tube. Once you are asleep, Eva then will be placing a Foley catheter to drain your urine. We want to keep a close eye on how well your kidneys are working. In addition to that, what anesthesia will be doing is placing a second IV into your arm somewhere where we can find a vein. And then in addition to another IV, we place it's sort of like an IV. It's a catheter that goes into your wrist. It's an arterial line. Again, you will be completely asleep for this. What the arterial line allows us is to drop blood samples throughout the case and watch your blood pressure on a beat-to-beat basis. So this is the anesthesia machine that we have, and this is the monitor, which it watches your blood pressure, your oxygen level, your heart rate, and your temperature. Temperature is definitely can be challenging in the operating room when it's cold. In addition to what Eva had mentioned for our warming devices, I also have a warmer up on top. So your arms will be out on this side, and we put the warming device here as well. We do have a fluid warmer to help for IV fluids, as well as if you would need any blood products during the surgery, and an underbody warming mattress as well. One more thing that anesthesia does at the head of the bed when you are asleep is placing an NG tube or a nasogastric tube. This will be done when you're asleep. It goes into your nose, down your esophagus to help kind of drain bile and air. So you'll be waking up with that as well. It's sort of a soft little tube, which I have right here. So you'll be waking up with this tube, so that'll be in as well when you wake up, and you'll be in the recovery room. And again, that'll be going in when you're asleep. Throughout the surgery, we're monitoring all your vital signs. We're adjusting accordingly with medications, the depth of the anesthesia, as well as blood if need be. We give you pain medicine during the surgery, as well as other medications to help prevent nausea. What the surgeon does, then Dr. Evans or Dr. Christians will, before they close, they will be injecting, kind of like at the dentist, some lidocaine. It's a longer acting local anesthetic into the incision site for another source of pain control for you. Once the surgery is done, and we feel like we are all set to wake you up, we turn the anesthesia off and we let you breathe the anesthesia gas off slowly, and then you'll kind of wake up to consciousness. The overwhelming majority of the time, we can get the breathing tube out at the end of the surgery in the operating room, and then we transfer you to the recovery room.
So all this stuff are basically energy devices, warming devices. This is a machine for, it suctions fluid, and it has a screen that you can see, so it gives you an estimate of how much fluid is lost. This is our warming device. The energy devices cut and coagulate tissue to allow the surgeon to work more efficiently. And then we have laparoscopic equipment here, so we can hook up a camera. And the images are then projected on all these screens so that everybody can see and can follow the procedure. It allows me to anticipate more efficiently what the surgeons might need. It's good for the students because they can see what's going on and they can really follow. We have a light above Katie, which will be shining above the patient during the procedure, and that has a camera in it. So when we're not using the laparoscopic equipment, we can look directly into the wound and follow on what's going on in the procedure. All of these instruments that Shira is setting up over here will need to be counted. And we count at the beginning of the procedure and we count at the end of the procedure to make sure that everything is good, nothing's left behind. Very important to do that. We have another machine here, which is a situate machine, and that will, if there's we scans the patient to detect anything that may have been left. It has a little radio of tag at the inside the sponges. Can you show him, Shira? That little thing. So if anything is left in a patient, it'll detect it and alarm. So that way, that's just a final safety check, but we always verbally count and visually see everything as well. There's a mattress under here, a nice squishy mattress that is part of that whole process there.
So then once your surgery is all done, we'll make a great effort to get the breathing tube out in the operating room here. We will put some supplemental oxygen on, a nasal cannula or a face mask. Eva and I will then help you from the table to a more comfortable bed, put your head of the bed up, and then we will get you to the recovery room.
And they're expecting us. We always call ahead and let them know that we'll be coming. And then we head on out the door. And Takes just a couple of minutes to get to the recovery room. And then from there on, those nurses take charge.